on age-related macular degeneration. So age-related macular degeneration is a very important topic as the eyes is very important to us. And we, as clinicians, 64 to 74 years of age. So 10% are seen on people over 65 years of age and 25% over 75 years. Another non-modifiable risk factor is that if they have identified the gene, the complement factor H gene, which has the predominantly the more late age-related macular as compared to the Japanese and the Malay. So these, the others are the modified because this hypertension leads to constriction of your blood vessels, therefore diminishing the nutrition of your retina and therefore restricting the oxygen flow. So another modifiable risk factors is high fat diet because high serum levels of polyunsaturated fatty acids would cause accumulation of your category 1, which is small, less than 63 microns of yellow dots. Blue vessels are formed, which also are leaky and causes fluid accumulation. Therefore, the endothelial growth factor agents, which we inject inside the eye. So, because age-related macular degeneration, no?
Because it is one of my favorites. So, for the title, Insights, Concepts, Standards in Medicine, very interesting, no? Icons. Medyo mabagal naman. 10 years, 15 years ago, siguro kamukha natin si Lisa Soberano, no? And then for our classmates we've seen, you all look handsome, the same as how you look.
Products. Now, looking good backed up by science would include, of course,
there's also a change
and an evolution into this thing. We want to achieve symmetry because basically we know from our professional medical doctor, dermatologist, or a cosmetic surgeon because we want to achieve symmetry. Weight loss, it may also be some patients come to you just wanting to feel good. They don't have any disease, no acne, no pigmentation, no sebaceous hyperplasia, but disease that probably we would encounter a lot in our clinic. Maybe 60 to 70% will be mechanical peels. And of course, nowadays we have the lasers and we call them energy-based.
I'm the son of Dr. Aguirre. But bata po ako tingnan, but my heart. On June 6, 2012, I had the biggest surprise of my life. I had a heart attack. It was after 8:10 or 8:05, I saw myself in the mirror. I was so pale, white, and I was already having difficulty of breathing. I'm sure tomorrow I'm gone. Naisip ko, masaya naman ako sa buhay ko. I've traveled a lot. I've been successful again, and let's go to the hospital. So I climbed, I walked down the stairs again, then we rushed ako sa hospital. So wala na po ako alam dyan. Unfortunately, during that time, all the cardiologists and internists were in Manila, Mikaya, for a conference. So I shouldered everything. Tapos, so 2015, 2012, I started my new business. Actually, 2006, I put up my first business. I put up my own ambulatory surgery center in Roa City. Pinag-initan din po ako ng PhilHealth noon, but fortunately, naka-recover ako in 2010. Nag-start na po siya. It was accredited by DOH and PhilHealth. And I would also like to thank the father and the family of Charm Gonzalez and her dad, Mr. Honorable Raul Gonzalez, for helping me out there too. So, ngayon, natutulungan ko na yung mga patients ko na mga indigent, no need to call only the hospital. No syringe, no medicine, it will be all mine. Kahit gasa, lahat po, walang gagamitin sa hospital. Only the operating table.
Thank you, Dr. Aguirre, for sharing with us your personal journey. I know it was very emotional. And as they are taking pictures and receiving their certificates, we'd like to announce that in the interest of time, we will do away with a 10-minute break. The snacks will be served.
First, our first lecturer.
Approach to myoma management. As you know, myoma is the most common benign gynecologic pathology seen in women. 20 to 40% usually seen in the of cases, gynecologic cases seen in the Philippines out of 32,000. We have to remember that malignancy
Dr.
in
Noemi
myoma is
Panglao Salazar for Assessment and Management of Developmental Disorders.
Thank you very much, Marga. For today, I was tasked to talk on the assessment and management of development problem. Okay, so you often hear parents saying this. My son is already 3 years.
Refresh you. If you, these are actually the red flags for your first year babies, no? So in the newborn, if your child does not startle in response to loud sounds, does not respond to sound, music, or familiar voices, at 4 to 8 parents that we do hearing tests. Now it is almost all universal. Well, at least in the Philippines. So management, we do amplifications, the hearing aids for infants and children,
Occupational, or other important areas of current functioning. And you have to be very sure that these disturbances are not better explained by intellectual disability. Okay, so we now come to the assessment and management. How to assess for the primary physician. Of course, you will always have to get very good history and physical examination. A developmental history, meaning you have to take note of the age of achievement of the different developmental milestones. And then for the primary physician, you may ask the parents to do or to fill up a questionnaire, the MCHAT or modified checklist for autism in toddlers. And currently we're using the PEDS. This is the Parental Evaluation of Developmental Milestones, wherein we ask the parents of their concerns. No? So for the last two, if you think...
PCNL, it is, if you have those cross ball pen, a very fine ball pen, that is how big the
advantage: decreased post-operative pain, better cosmesis, faster recovery, shorter. Just give credit to the one who discovered it, and for you to show to you, this is how robotic. But I would like to highlight greater surgical precision, because all the other benefits are also achieved in laparoscopic surgery. At this point, I would say,
had supposed. As Tomasian doctors, we are not just clinicians. We are educators and researchers. If I may share with you as my last slide, our UST HIN that was already institutionalized in 2013, it goes, ako ay tumasinong manggagamot, lumilingon, tumutugon sa harap ng hamon. Kaalaman laging palalawigin, buong puso sa iba'y ito'y sikap pagyayamanin. Ako ay tumasinong manggagamot, naglilingkod at nag-aalay ng talino at buhay. Dangal ng pananaliksik, sisikapin upang hirap ng kapwa natin ay papawiin. Two beautiful stanzas in our UST medicine here. And as Tomasian doctors, we are continually searching, seeking for excellence. Thank you for your kind attention.
The head of the Department of Otolaryngology had the neck surgery at the Rizal
surgery. So I finished in 93 with my batchmates. So wala pang sleep lab in the Philippines there. And it cuts through all specialties. All races, all ages, all sexes, and all, as I mentioned, all specialties. Kasi important, a third of our lives, quality sleep. So it's not just like turning off your car
we were always, having said that, this is where the science comes in. And then we're going to talk about how we address a person who not only snores, but who stops breathing. It's like lungs. No? So anything above the Adam's apple or the thyroid notch or cartilage, above that, of course, upper airway, because that is the landmark. They used midazolam, they used propofol, okay. They measured propofol using bispectral index guided infusion of propofol to make sure that you're giving the right amount and also having the desired effect to look at the upper airway, no? So, just for orientation, ito yung vocal cords, eh. Okay? Epiglottis, tongue base, okay? The collapse of the upper airway can be in the base of the tongue, can be in the side of the throat or the oropharynx.
In this room, who has tried using a CPAP? Okay, ano ba yan? It's like going in front of a fan. Okay. Good airflow or a laminar airflow. As you exhale, parang vortex only through the nose. If we sleep with our mouths open, there's something wrong. Okay? And that's why I said it cuts through all specialties. Di ba, sa bata, when I was a clerk here, yung adenoid fascies, di ba? Sabi, mabubuting pediatrician consultants natin. Dapat, yung mukha nila, dapat hindi yung nakabukas ang bibig. Okay? Kasi, when you have the triathlon, di ba? You have running, you have biking, you have swimming. Among these three sports, there's only one where when you compete, your mouth is open, and that's swimming. When you're running, when you're sleep, there is increased nasal resistance. Yung sinasabi nila, Doc, one side barado, the other side lying down. That's central venous pressure changes. So by gravity, the pressure in pag APAP mas mataas, pag BiPAP mas mataas, can be from 25 to 30. Okay, so what happens when, okay, ito na yung one by one. So there's the nose, not very much, mga ilan percent lang, 20% lang. No? Actually, let's go back. No? About 16% lang. By this slide, based on what is also being done here, we do nasal surgery, we do tonsil surgery, we do palate surgery, we do skeletal surgery, and just as long as the airway, patients respond well. But the problem is, will they want to be well the whole time? Kasi patients who have sleep apnea, you have to monitor them lifetime. I'm showing this slide because so many palate surgeries are being done. You don't anymore know which is effective. So when I lecture this to the ENTs, to the head surgeons, I tell them, practice a surgery which you get the best.
Dr. Joseph.
Hi, I'm Joseph Africa doing some experiments. But it was not until a few years after that when Dr. Alexis Carrel popularized vascular as a young patient who died because of ABO incompatibility. It was not until the 1950s when two landmarks were noted. The first is the description of the conventional renal transplant on a 40-year-old man. So it was a small incision. It's a midline infraumbilical incision using laparoscopic instruments, and it was really a success. But there was resistance to the acceptance of that procedure. In fact, an editor in one of our journals said that it's a bad thing for transplantation because why would you change what's a safe surgery for donors for over, and then of course it's nicer to look at, so there's an aesthetic component to it. Now just quickly, there's a minimally invasive open technique. Most of the reports are actually in thin patients, and I will present to you our paper on obese patients. And then there is the minimally invasive laparoscopic or robotic surgery. This is the robot that we talk about, right? In our center,
in the nose, okay? And then we're gonna place the silicone tubes to make sure that it doesn't close, because anything that you incise, it will close. The body will tend to heal itself. So this is the only procedure that we don't want to heal. Okay, so we place the tubes, and then we also place mitomycin C. It's an anti-fibrinolytic agent. We place it there for 5 minutes, so that it won't scar it. Okay, and the hole will be patent, so the patient won't tear anymore. Okay. This is after 2 months.
This quote, no? Ars longa vita brevis. Do you know where this is? Okay, it's just outside the med school.
For the interest of time, if you want to have...
I'd like to turn over the podium now to Dr. Peralta for their session. We have a working break. You can partake of the snacks. You can just go out of the CME and eat and then come back for the lectures.
Hi, good morning fellow jubilarians. Good morning. Are you tired?
Magandang umaga po sa inyo lahat.
Magandang umaga din. Morning po.
Punong-puno ng class 1973. These are just my test slides, so let's just move on with that anyway. Pero we've been waiting for this because it was accidental that I am here in front of you and I'm talking before you. When I saw the announcement for our reunion, I found out that 2 of my classmates were going to speak and be participating in the Mariano Alimor lecture series, which we did 20 years ago. And I know that Joe Yamamoto and Marilu Uson Peralta were supposed to be speakers. So I said, oh, okay, I'll join them. Little did I know that both of them would be moderators, and I was left to be just the speaker. So, nonetheless, I took it as my way of like having my class. Because if I remember right, 20 years ago, we were doing the same thing. So, this was full of jubilarian celebrants at that time. So I know how you feel. And so we folks, we would like to share with you our sentiments. Look at us, because 20 years from now, this is how you will look. Anyway, of course, for every new year, you should have a resolution. And this is one of my resolutions. So I hope you will all get fat. Or, as I reached, well, the sermon of Father Manlangi this morning mentioned something about when you are almost like reaching the age of 70, you would like, you're all mostly like getting into some sense of perfection. To me, this is my sense of perfection. Or we could watch Game of Thrones. We don't know what happened to Jon Snow. So hopefully this might be a better way of like talking about it rather than me giving you a lecture. But Game of Thrones, is it popular here in the Philippines? Or, of course, our dear friend Jack Nicholson. We just have to deal with it, and we would. There's so many aspects of our lives: social, religious, even business and financial aspects. Okay, healthcare actually provides that kind of way of living for most of us. Or if we get ill, we could repair whatever is ailing us. Now, beyond that, healthcare is also important for at least like things that would like tweaking on nature, okay, like cosmetic surgery. It's not necessary, but we deal with it, but eventually cosmetic government or national insurance who will be paying for it. And where do they get their money? It's still also coming from taxes, from people. So when certain aspects of payers are involved in healthcare, they want their value of payment as the most reliable way of giving their money. And how do you then get that value out of what you're paying? One of them is accreditation.
Usually like asked to survey with someone whom I really don't know.
Like when I did Abu Dhabi, I was paired with someone who is from Connecticut and another one coming from Michigan. The three of us would meet the night before the survey, and then we would talk about what we're going to do. And I usually would be doing the program surveyors. Someone else would be doing the administrative surveying. And that's how we do it. We do it for like, internationally, we do it like in our first year. Look at this, okay? And look at our women. Gradually, their hemlines are going up. And look at this, when they were now clerks. The hemlines are higher up, whereas we're all wearing male students at that time, and we called ourselves Tibata. We were looking beyond what we were. Okay? But, beyond us, 20 years or 45 years later, we have some prominent class members. And I would like to please acknowledge Joe and Mila Yamamoto. Okay? Because they've been really helpful to us. And from us, from the United States, we have this couple. The lady, Terry, actually started us using Viber. No, all of you probably are using Viber in your class. But this couple started our class really moving around. Was a PMA president. Okay. And we have, within our class, the Dean of Perpetual Help, Winnie Xiao. Okay? And the lady to the far right is Fidela Moreno, who made a lot of our...
Of class 1993. Another jubilarian. There, he is a colonel. He is a colonel of the year.
My stage, of course, practicing airspace medicine or as a flight surgeon. So I have nothing to disclose. So my topic will be talking about the Navy or the like, or NASA. So a military practitioner of airspace medicine is what we call a flight surgeon. So I'm not technical surgeon, so it's just a name. So people kind of have that thinking we operate during flight, which is not really. I'll see you. So this is what we call a centrifuge, where it goes around, goes to about 9 Gs. That's usually what the fighter jets are flying right now, make sure that they can tolerate the pilots. And we also do mixed-up investigations, dealing in the aspect of the health of the pilot who was involved in the crash. So we're not thinking about exactly what happened to the plane, but what happened to the pilot. If there was any factors involving this mishap here. Because the physiology of the mission also, for diving, it's after the mission, and joint pains are more common in altitude, while neurologic symptoms will be common during diving. And treatment will be a bit different also. Going down, from up 20,000 feet, go down, you get better. However, or going down to sea level, this will do better. If you go to sea level here, it's going to get worse. So you don't do that. So for the bubble content here, for altitude here, it's usually very soft because it's mostly, a little bit of oxygen there. Because while diving, it's most differentiate somebody having these symptoms. So pulmonary symptoms basically, but can also be seen with spinal DCS, and it's life-threatening, so immediate, recompression. For staggers, like somebody's having too much drinking from like last night. So you have the symptoms here. So depending, so cerebellar, incoordination, cerebral, which is the most common thing that happens, and it's very fast. So you can have headaches, water level, and slowly, between oxygen and air, recompression, and then slowly ascend, lower the pressure. So altitude sickness is going to be similar to it, but mostly from hypoxia, from high altitude, which rapid ascent here to as close to even 1500 is about what?
A Tagalog version of that. We got the permission, and we are now doing the pilot testing right at this very moment in one of the prosthetic and orthotic clinics here in the Philippines. We've done the WHO forward and backward
You are
translation of that.
conducting your PROMs and you belong to a big hospital. The question there is, will the hospital allow you to do that? Especially if it may reflect on the performance of consultants in a hospital. So you need to ask permission. No? And that can be a big factor. And lastly, when you say miscellaneous, of course, cultural sensitivity is one. Confidentiality is one. I wish everybody a pleasant morning, good afternoon, and a good day.